Good morning, everyone. We have a robust presentation for you this morning, so we're going to go ahead and get started. My name is Kate Elliott. I'm a program coordinator for the Patient-Centered Primary Care Institute. And before we get started, I want to review a few things about the technology we're using today. Since we have so many of you on the line, everyone is and will remain on mute throughout the presentation. We do have time set aside to take your questions, though. And when we start Q&A, there are two ways you can ask a question. We would love to go ahead and hear from you directly. To do that, you can raise your hand by clicking the hand with an upward-facing arrow on your control panel. I will introduce you, unmute your line, and you can go ahead and ask your question. In order for me to unmute you, though, you need to enter your audio PIN into your telephone keypad. You'll see up here on the screen there's the number that you dial in, the access code, and the audio PIN is a number that's unique to you. And you just can enter that into your phone now or at any time during the presentation. If I see that you've raised your hand but you haven't entered that PIN, I'll send you a message with the PIN and you can enter it at that time. If you have trouble with that feature, no worries. We welcome your question via the questions log on the control panel. You can go ahead and type it and I will read your question for the presenters to answer. You can also feel free to send me a message via the questions pane, and I'll do my best to assist you. My login here is PCPC Institute, so if you send that message to me, the organizer, I can help you out if you're having problems. Please note everyone's favorite question is whether or not we'll have a recording and slides after the webinar, and the answer is yes. Everyone who's on today will be sent a copy of the recorded webinar and a link to the slides, so I can save you that question now. So this webinar is hosted by the Patient-Centered Primary Care Institute, which is a public-private partnership launched last year with the goal of advancing primary care home transformation in Oregon. We're working to provide an array of technical assistance to practices that are at all stages of transformation through in-person and web-based training opportunities. Earlier this year, we partnered with 25 practices from throughout the state and specialized technical assistance providers who will work with those practices through the rest of the year. We also want to reach practices outside of that group through webinars like this one and by adding materials to our website, which we'll reference a couple of times today, and you can visit it online if you haven't at www.pcpci.org. We encourage you to sign up for our email list at the website. That's how you'll know when there are major updates to the website or new in-person training opportunities offered by the Institute or our partners. Before I hand things over to our presenters, I want to briefly review the Oregon Patient-Centered Primary Care Home Program's model of care, which includes 6 core attributes that are listed here on your screen. Each attribute includes specific standards and measures, and practices attest to these in order to become a recognized primary care home. You can visit the PCPCH program website at primarycarehome.oregon.gov for more information on the standards and becoming recognized. Now that I've shared some information with you about the Institute, I'm going to go ahead and turn things over to our presenters today. Bev, are you ready to get us started?
Sure. Good morning, everyone. I'm Bev Johnson. I'm President and CEO of the Institute for Patient and Family Centered Care, and want to welcome everyone. I am greeting you from rainy Bethesda, Maryland. I feel like I'm just in sync with all of your communities in Oregon with our rainy weather today. I hope that the Institute for Patient and Family Centered Care will be a resource to you as you begin to partner with patients and families and develop primary care homes throughout the state. Our faculty today, I'm joined by Patty Black, who is a patient leader. She serves as the patient advisor coordinator for Peace Health Medical Group, and Mary Minetti, who is a member of our staff, and she serves as a program and resource specialist for the Institute. Both Patty and Mary are based in Oregon. I also want to acknowledge the support of the Robert Wood Johnson Foundation in supporting the preparation of this webinar today. In our time this morning, we will be sharing with you information about the benefits of partnering with patients and families in a variety of ways, in program development, in quality improvement, as you develop primary care homes in Oregon, and in other initiatives to redesign primary care. We've learned, and I think it will be important in your work to discuss how you really prepare staff and clinicians and leaders to collaborate effectively. It's not rocket science, but there are best practices that we've learned in working with lots of ambulatory practices across North America and even around the world. We hope that in our discussions today, you will identify and see other opportunities where patients and families will be useful partners with you. If you go back to the joint principles for the patient-centered medical home, this idea of partnership at all levels of the practice was embedded in these joint principles. I'm not sure the folks who signed, the organizations who signed these joint principles at the beginning really fully understood what this would mean in terms of implementation. So much of what was driving the joint principles was the need for payment reform, which is absolutely critical. And we even need to partner with patients and families in helping both at the community and state and national level that we move this agenda forward for payment reform. But there were other specific ways that the joint principles articulated the importance of partnership. First, at the care level, I love the way they worded this, a care planning process driven by a compassionate, robust partnership between physicians, patients, and the patient's family. So at the direct clinical encounter, there is collaboration and really authentic partnership. There is the second core concept here is actively participating in decision making. I think at the other level, the joint principles talk about partnering with patients and families in quality improvement at the practice level. And that's what we're going to be talking about primarily today. How really you can successfully engage patients and families to be your improvement partners. We ground all the work in the redesign of primary care in the core concepts of patient and family-centered care. We define it as an approach to the planning, implementation, and evaluation of healthcare that is really the foundation is mutually beneficial partnerships among patients, families, and healthcare professionals. And the four concepts, they're quite simple, but they serve as a framework for quality and safety work. People are treated with respect and dignity. That means all patients and families, but it also means all your staff, clinicians, those who work in the ambulatory practice, those who work in the hospital. The second core concept relates to how you share information. You share useful information in ways that are affirming to patients and families. The third is you really encourage and support patients and families in participating in care and decision making. We know we get the best clinical outcomes when they are active participants in their own care. And lastly, collaboration. And then again, reflecting like the joint principles, it's collaboration in the clinical encounter, but collaboration at the practice level. And if you're an academic practice, it's also partnering with the patients and families you serve and teaching the next generation of clinicians and staff, and also in research that they can be partners with you at all phases of the research agenda. A short way of thinking about this work is patient and family-centered care is working with patients and families rather than just doing things to or for them. I know many of you are working on the triple aim, and at our international conference last June, Don Berwick said the most direct route to the triple aim is via patient and family-centered care in its fullest form. So as you work to improve the patient experience, the health of populations, and reduce costs, that really is possible. And the resource you have to do that is to partner with your patients and families to help figure out how you do that well. It's not that you all aren't smart people who've had a lot of training to work in ambulatory care settings, but patients and families bring a unique perspective and expertise that complements your knowledge, experience, and expertise. You may have heard frequently the terms patient and family engagement, particularly after the Affordable Care Act was passed. People use these words as interchangeable with patient and family-centered practice. They're really not exactly interchangeable, but they do speak to really a strategy of engaging patients and families at all 4 levels of healthcare, in the clinical encounter, at the practice or organizational level, at the community level. They can help you build those bridges with community resources and strengthen the connection between community resources and the practice. And at the policy level, both locally, regionally, and at the national level as well. There's a wonderful new book out that was published this summer that may be a resource to your practices. It's from the Institute of Medicine called Best Care at Lower Cost, The Path to Continuously Learning Healthcare in America. And one of its key recommendations was to have patients and families on the learning team in healthcare organizations. And they felt, and here you'll hear the echo of the triple aim, when patients, their families, other caregivers, and the public are full, active participants in care, health, the experience of care, and economic outcomes can be substantially improved. They also speak to involving many of you as part of your primary home development are developing electronic health records, implementing them. This report speaks to involving patients and families in that, as well as in the training of clinicians. So you can get this report from the Institute of Medicine. There was an article published a couple of years ago by Rich Barron and Charlie Homer that really talks about the change that's required with the medical home. It's a radical change requiring both a new mental model for primary care and the skills and resources to accomplish it. So I'm hoping today we really are helping you see what kinds of skills and what resources are out there that can help you in partnering effectively. And they also speak to that family members bring in a perspective that's incredibly valuable. They talk about refocusing transformation efforts away from provider concerns and towards bringing value for patients and families. I would caution they will help you make this a better workplace for staff and clinicians. So what is nice about this is it benefits patients and families, and it also benefits the quality of the work life for clinicians and staff. Just a couple from the national perspective, a couple of best practice examples. This is a safety net clinic. It was part of a Team Up for Health collaborative. Humboldt Open Door Clinic is in Northern California. And one of the best practices they did at the very beginning when they started to partner with patients and families was to appoint an administrative leader, someone who would be the executive sponsor of the work in this safety net clinic with patients and families. And that clinic administrator also then said, I want part of some person's job to be the staff liaison, to work directly with patients and families, to be kind of the go-to person. And this person that he selected had very strong facilitation skills. And so both of those things, having a leader and having some dedicated time as part of a position, is staff liaison. I was worried that we might have sirens this morning. Sorry for the distraction. And you can see on this list how they partnered. They worked on the phone system. They helped to redesign the bulletin boards. They helped patients know how to get the most out of their visit. Another example I wanted to share all the way across the country in Pennsylvania. This was a health system that was doing its second collaborative to implement the medical home. And they wanted both to understand how to develop the medical home, but they wanted to learn in this collaborative how to partner with patients and families. And here again are the best practices. One, to give guidance to each of the clinics that they each should have at least 2 patients on their medical home implementation team. They would be real partners, members of the team like everyone else. And they gave guidance. And Mary will talk a little bit later in the webinar about how to partner with, how to select the patients and families to be partners with you. The second best practice is they selected that each clinic have a staff liaison to be that go-to person. The other key thing that they did was to really prepare patients and families well to be partners in the medical home implementation. And they had a half-day orientation. And one of the things that I think was very effective, they were very transparent and shared with staff and clinicians what patients and families worried about whether they could be effective. They didn't know whether they knew enough to be an effective member of the team. And the staff and clinicians had expressed, you know, we're worried about partnering with patients and families because they're going to see us when we're not at our best. They'll see our worst practices. And they also may slow us down. And by sharing that with both sides, they were able to prepare people to work effectively and just be transparent and build trust in the way they worked. So I think you can read more about how they partnered, but continually at every phase, they prepared patients and families for the agenda, for the content, so they could be excellent partners in that work. I'm wondering if you have any questions for any of the examples I gave or any questions about what's happening at the national scene before we move on to the next presenter.
Hi, thanks, Bev. This is Kate again. So just a quick reminder, we're pausing for questions right now. If you have questions on some of the bigger picture ideas that Bev talked about, we're going to take, we can take a couple questions and then move on to our other presenters. So are there any questions? Remember, you can raise your hand or you can type a question to me and I can read it for you. We'll give you a couple seconds to gather your thoughts.
We will have time for questions at the end. So if there are not any questions at this moment, I'd love to introduce Patty, who will take over and share her insights as a wonderful patient advisor and leader in a medical group.
Thank you, Bev. Good morning, everyone. I'd like to start this morning by sharing a little insight. I have been an advisor for 5 years and the coordinator of Peace Health Medical Group's advisory program for 1.5 years. But I'm also a gardener. And I have learned that gardening is a process. It's not an end result. And that's not unlike healthcare. It takes time and effort and a good deal of patience to create a garden. And it takes time and patience and a great deal of patience to create good, safe, patient-centered healthcare. So plant your seeds today, don't give up, and you'll get your flowers tomorrow. Oh, I seem to be having a little trouble advancing. Kate, would you like to advance my slides? For some reason, it's just not working on my computer.
Go ahead and try and click one more time, Patty, and if not, yeah, we'll go ahead and move them forward.
Okay.
We'll go ahead and move the next one for you. So just
All
go ahead
right,
and say
thank you. It's just, yeah, it's just not working.
no problem.
Okay. Often people agree to become advisors because they or a family member has had health care that was less than optimal. Or some people become advisors because they've had care that was so fantastic that they are so appreciative they want to give back. Well, whatever the reason, they wish to use that experience to help other patients and, as well, all healthcare providers. When we started our advisory council, we started with a few simple projects first. Reviewing patient educational materials is a great place to start. That we can learn about literacy levels, we can learn about content, font sizes, we can talk about patient demographics, readability. But we have to be careful when we do this. If we do it too often and too much and we don't instill other kinds of projects, because advisors really want to be more, a great deal more, than an extension of your marketing department. Wayfinding is another great place to start. Take tours. You know, do your signs make sense? Do they get your patients where they need to be? Art selection projects are a great place to start as well. We also dealt with a lot of safety issues, hand hygiene campaigns, med reconciliation projects, parking lot lightings were great places to start. As a new advisor, I got to participate in an AARP program up in Portland around patient safety, and our advisors that attended that came back to our advisory council with this idea of having our own DVD, and we were able to put one together, and it's entitled Your Healthcare and Safety, the Team Approach at Peace Health Medical Group, which is still on our website today, and it's still being handed out to all new patients that come into our organization. Access to care is another great place that patients can start. You know, paying attention to your phone service. You know, does it make sense? Is it cumbersome? Helping new patients find new providers, the new patient packages. We worked a lot on those, and as you know now with the medical home design, same-day appointments is another key place where patients can have an impact. Okay. Next slide, please. I've included this slide to share with you the benefit of making the collaboration apparent to the whole organization. Our council went to our executive leadership with clear, concise goals and objectives, one of which was to be included on our organizational chart. And when we did that, it sent a clear signal that we were to be taken seriously, and that's when the true partnership began for us. Now, I'm able to take our organizational chart and share it with all new managers, with providers, and with potential patient advisors to show them where we fit within the organization and who we report to, and that we really, truly are taken seriously. Next slide, Kate. And here we are collaborating with our front office professional training program. Advisors helped with the course content, with the teaching methods, and with the scriptings. We were at the table from the start. And one of our advisors was so moved by the project that she went back and wrote a poem sharing how important the frontline office staff is to every patient. We now have included her poem in the training, and it inspires the staff and helps them feel more valued and appreciated. Okay. Next slide. Not too long after our PAC started, A few advisors got to go to the Institute of Patient and Family-Centered Care seminar in Dallas, Texas. There, we learned how beneficial councils can be, not only to the healthcare organizations and to providers, but to other patients and to themselves as well. We got to learn what other councils were doing in the country, and I'll tell you, it lit a fire under us. We came back with great action plans and lots of ideas. So a year or so later, through a grant in partnership with Q Corp, we were able to mentor others in the state of Oregon wanting to start advisory councils themselves. Now, our group even had a bigger fire lit under them because we could see the possibility and the benefit of networking with other patient advisory councils. Now, switching gears here, my role as a coordinator, interviewing and preparing advisors. We want people who have had lots of experience receiving health care, or people who have taken care of others, people who may have had less than ideal experiences but can be tactful, respectful, and that can understand many points of view. That is so important. I mean, those people are worth their weight in gold. Now, you have to be careful because you don't want to bring someone on too soon if they've had a recent difficult experience. As we all know, it takes time to heal, and so we've made it a little general rule of thumb that we would like to have someone at least have a year before they set on the council. We don't want anyone with a hidden agenda. You know, that's not helpful for anyone at the table. Nor do you want to bring someone on too soon because maybe there's a topic that's being discussed that might really be very difficult for them. Now, orientation is key. I mean, I cannot emphasize this enough. We spend a good deal of time doing orientation. Oh, we went too far. Okay. We spend a good deal of time going over our notebook, and in our notebooks we include our mission statements and our core values, and we go through those quite extensively just as if those new advisors were new employees of the organization. We review team agreements, confidentiality contracts, our charter, healthcare nomenclature. We share lots of information on how to share stories. And we also cover past minutes because that has seemed to really help bring people up to speed a little bit quicker, knowing what we've been talking about and what we've been dealing with. It's also important because this is such a lot of information to be given a new advisor that you do check-in calls maybe during the next couple of weeks with them to see if there are any questions. I have found that to be very, very helpful. And then that sort of gets into mentoring. We mentor a lot through education and always sharing and encouraging and how valuable our patient advisors are. We give them constant feedback. And I can't emphasize enough to show up your appreciation and celebrate the successes and have fun. I mean, these are volunteers here, and to mix it up some so they really want to come back, not only for the good work that they can do, but because it's a fun environment. Now, I found that preparing staff is really very similar to preparing a new advisor. I go out with an information packet, and in that information packet, it's all about us, the Patient Advisory Council. I give these to all medical chiefs, to all the division operation managers, to department managers. And in that packet is included our schedule to show that we have team agreements. I share our charter. I share the fact that we do have confidentiality contracts, and we take those very, very seriously. I also include a list of our accomplishments to date because this, I mean, not only can I brag, but I can share with them what kinds of projects we've been involved in. And, you know, that really gives a lot of people more ideas about how they can involve our Patient Advisory Council. I've also included a request form, and I found this request form to be very, very helpful for helping people clearly define their goals and their project time commitments and their expectations for advisor participation. Then I'm able to take that to our advisors and show them the scope and the parameters of a certain project and see if they really truly are indeed interested. I can share a little story about why we came to this point and finding out that we needed a request form. We had a project manager who wanted a couple advisors to come help choose some artwork for a lobby. And the project manager knew the parameters, that they were to come and choose 15 prints out of 30, but the patient advisors didn't know that. They thought they were going to come and spend, some hours poring over different kinds of art, and I don't know this for sure, but maybe they had high hopes that they were going to get to put huge statues and wonderful waterfalls and all kinds of things in the lobby. I don't know. But when they got there, it wasn't what anyone had expected. And the advisors did not like the prints. They didn't like the quality. In fact, they didn't even like the frames. And so the project manager was taken aback. She didn't really know how to go from there. She knew that these prints had already been purchased, that these were the artwork that had to go on the walls. And so this person never did get back to the advisors, and we lost an advisor over that. So we haven't had that problem since we have instituted our participation request form. So highly recommend that. Expectations for staff. I'm able to share about what goes on within our meetings, and I promise them that our meetings are run on time and that they truly are. With our meetings, our chiefs and our operational division managers each rotate to one of our meetings. So someone from the organization, from the different departments know exactly what's going on. And then this is a really wonderful thing that I get to do. I get to share how important the value of partnership is. And I can promise them, and I share this to each person that comes to our meetings, that you will be amazed by how much our advisors care about you and your job satisfaction as much as they care about the patient. And I find that when people come to our meetings, I would have to say 99.9% of those people ask if they can come back. And so that's really exciting for us. The last slide that I'd like to share with you is the newest project that we've got. Our PAC has a yearly budget to do a project of our own choosing. And this year, we particularly wanted to help with appointment efficiency and patient satisfaction. So we've designed this, what we call our agenda setting notepad. And when each patient checks in, they're asked to list their top concerns for today's appointment. And if the items listed need to be negotiated, then that can happen in the exam room. We have found that as patients, we really do need to be educated to help with the new way that care is delivered. And we thought we could do this with an educational tool to help patients become more engaged around time constraints. They can become more organized to eliminate the, oh gosh, doc, one more thing as a doctor's leaving the room. So, and we also hope that by having their top concerns met, that they'll leave with greater satisfaction that those top concerns were indeed met. Now, this project was done with a collaboration of our adult and family medicine team and providers and our marketing department, as well as our patient advisors. So thank you. Now I'd like to turn it over to Mary Minetti.
Thank you, Patty. I so appreciate it. So we'll see if I can get the slides to work. Not sure what that's about, Kate, but if you can move to the next slide, that would be great. I know we had this working earlier. One of the things that's really important to remember about collaboration is something that Bev said, and I think we heard it in Patty's, but it can't be overemphasized, which is when we're working in partnership with people, it's not a situation where whatever they say goes, but it's really it's the ability to co-labor together to create something that's better than each of us individually would have been able to create. And so I want to talk a little bit about, next slide please, Kate. I want to talk a little bit about preparing the staff and leadership for collaboration. When I worked as the quality director for Peace Health Medical Group, leadership was very interested in collaborating and becoming more patient-centered. However, what different people think about collaboration and how it might work is different, having had some experience in another community. So in order to really check to make sure that leadership was on board, we wanted to work with both them and influence leaders in the organization so that we could create authentic partnerships with patients. I'd unfortunately seen the examples of what I would call insincere partnerships. We've included, and it will be posted on the website, what's called a checklist for attitudes. And with the executive team and the physician leaders in the organization, we actually had each of them fill out the checklist for attitudes, and then we had a conversation about whether or not what people's different attitudes were about partnering with patients and what that meant to them. The other thing that's important to do before you bring patients and family members in as advisors in the organization is to debunk the myths. Oftentimes, there are many myths that are out there that patients are going to ask for things that we can't do, that the office visit is already extremely stressful and I can't get everything done, and somehow there's going to be more burden on me than before. And so it is important to debunk those myths, to share examples of ways that different patient advisors have helped save the organization money, and to know that patients and families are just as sensitive to the cost issues, and they want to partner in a way that makes a positive difference. Bev talked about the WellSpan group. So one of the things that the leaders have to think about is what's going to be the format in which we're going to invite patients and families to partner with us on different quality improvement projects, perhaps different designs of new medical clinics. And you basically have two choices, and you can use both. One is to invite them and integrate them into already existing quality improvement teams or work teams. A number of places have done that. They might have a particular pod that's working on some things in their particular team, and they can bring 2 or 3 patients onto that pod to work with them in partnership, or to create an advisory council, which Patty talked very succinctly about. It is important to identify a liaison, and one of the things, for those of you that are on the call that have small rural practices and you're thinking people are really busy and they're not going to have time for this, you'd be surprised how many individuals want to have the opportunity to interact more with patients and will make the time in their schedule without compromising their other work to be able to provide a bridge between the patient and family to help invite them into the situation. Next slide, Kate. So one of the things that's so important is really changing the assumptions that you have, because patients and families can help in primary care transformation. Often when medical homes or primary care homes are started, a lot of the focus is on how are we going to impanel patients, how are we going to improve access, how will we begin to work as a team. And often the response is, well, we'll wait till we get everything organized before we involve patients and families. And I just want to encourage you to understand and appreciate the expertise that patients bring on their experience, and that the families are primary partners in the patient's experience. And so having those perspectives is extremely important, because your relationship with them is important, and you want to be able to do something that really embeds that relationship and fine-tunes it so that you can create the ability to work effectively together. Patient and family advisors often can give you perspectives that can help you actually do make adjustments to practices that may have a greater impact for patients and families than you realize. Next slide. So here's Community Health Partners in Livingston, Montana. And one of the things that I would say is that in medicine, for many years, we have not really invited patients to be full partners. We invite them in often to come to an exam and hear what we think that they need to do in terms of behavior change at home, and often aren't asking them what they would like to do. This is a great example of setting the stage and creating the expectation for partnership in clinical care. If you've been working with patients for a number of years and the way that you've interacted with them and the care experience has been to give them your best advice on the 5 things that would be great for them to do when they leave the practice. Sometimes they're taken aback when you ask them what they want to do. And so creating that expectation from the very front all the way into the exam room and with follow-up is really important. And they did a really good example of partnering with patients to create those messages. Next slide, Kate. So leaders and clinicians as well as staff in a primary care home are really trying to create a sense of teamwork. And so it's important to understand that teamwork and the primary care home is all around creating mutually beneficial partnerships so that individuals come back to that practice rather than using the emergency room as their main way to get care. And often that means that you have to focus on developing and building and improving the relationships and be clear as you're inviting them in as partners in care, but also as advisors in quality improvement to understand the many whys. Often people talk about using the 5 whys in quality improvement, often related to root cause analysis, but these whys are a little different. Why do you care to involve patients and families? What's in it for you? What have you heard from Patty or on the national scene that helps you understand what moves you toward being motivated to create those partnerships? It's important to ask the question, why haven't you started involving patients and families in quality improvement efforts? The Health Affairs article, themed article around patient engagement in February of this year, said less than 1/3 of practices that are working toward becoming medical homes or are medical homes involve their patients and families in their quality improvement initiatives. So if you started and then you quit, or if you haven't gotten started, address the fears of clinicians and staff and be clear about what the reason is that patients and families want to be involved. And it's not to control you, it's to make a better experience for themselves and for their communities. And so often meaningful partnerships with you are very important. They don't expect every idea that they have to be implemented. They just hope to be at the table and for them to participate in the decision making and actually participating in helping implement things. A great example of that was with Providence Medical Group here in Oregon, where they had an after-visit summary that was being used very infrequently by the clinicians, and the Patient Advisory Council said this is really important and we want to help increase the utilization of the after-visit summary. And they created posters for the exam rooms, in the restrooms, and they actually went to the different sites and helped put those posters up so that not only were they coming up with ideas, but they were providing an opportunity for people to see that they would pitch in and help in ways that they could do to make a difference in that particular after-visit summary. And actually they improved the use of the after-visit summary by 29%. And so that was very important. So they do want to be meaningfully involved, and they want to know that the ways that they've been involved have made a difference. Next slide, Katie. So I'm going to give you a quick tour of some other places. When you are wanting to invite people into partnership and provide them with useful and affirming information, positive first impressions are really important. And this is a great example in in a waiting area at A.F. Williams Family Medicine Center in Colorado, where they have gathered information together that really recognizes that people are each unique and that there are pieces of information. The patient portal sign-up is there. There's information on nutrition so that it's very engaging. Next slide, please. So invitation happens in a number of ways. It is important to interview patients and ask them some questions. And this doesn't have to be an in-depth interview. Often individual clinicians can refer patients that they think would be good to participate because they can see a bigger perspective, they have a sense of humor, they're able to listen. But it's important to ask questions like, what's been your best experience receiving health care and why is that? It can really help expand our own participation and perspective about patients. Find out why they're interested in being involved. Have they worked with groups to solve problems? Because oftentimes our patients aren't just patients who receive medical care, but they're people in the community that are doing all kinds of creative and wonderful things, and they bring those skills and talents. And then in order to really have your advisors represent the whole populations that you serve, sometimes it's important to understand if there are things that would prevent people from participating and help remove those barriers. Because if, let's say, you're a safety net clinic or you're a clinic that serves patients from all socioeconomic strata, you want to make sure that you remove any barriers so that every voice of the populations that you serve are heard. And then often you can find out the most interesting things about people by asking open-ended questions. So they may have some stories that make working as an advisor in a volunteer capacity really a meaningful experience for them because of some experience they've had or a family member has had. And sometimes you can find that out, and that's what really makes them stay at the table and value the relationships that they create with you. Next slide. So you want to know what their interest is, if they can speak in a group with candor. The value of patient and family advisors is that they are able to partner with you and share their perspectives. And so I've covered some of this already, but this is just a good reminder for you of the kinds of qualities and attributes you're looking for in effective patient advisors. And this is based on information from many years of working with advisors across North America. Next slide, please. So orientation can be something that, let's say, the team lead of a particular quality improvement project can do fairly quickly with an advisor. It doesn't have to take a huge amount of time, but it is important for them to understand the vision and goals and who's on the team, how the project that you're working on, that you're inviting them to participate in, is going to help the clinic achieve some of its goals. Just a general orientation about roles and responsibilities, how often they need to attend. That's particularly important. And in terms of attendance, I really encourage you to think about the times that you are holding your quality improvement meetings. Often they're during lunch, and it's the time that you can brown bag and do that. Some advisors, some individuals, because of their medical conditions, it makes it very hard for them to be at a 6:30 a.m. or a 7 a.m. meeting. But a lunch meeting or a right after work meeting often can work. And so depending on what you're working on, and if it's directly related to patient experience, we really recommend that you think broadly about how you can time it in a way that's mutually beneficial for both you and your advisors who are interested in participating. Next slide. So here's an example of creating an opportunity for advisors and clinicians and staff to learn together, and that's a way to really embed relationships and create an opportunity for a shared foundation. And these are some advisors and clinicians from Team Up for Health from the Sharp Reese Steely Medical Group, and they participated in communication training with physicians and staff. One of the things that's really important in a patient-centered primary care home is that communication piece in the office, in the exam room, so that there's really a connection made between the patient and the team members, whether they're medical assistants or they're clinicians. But patient advisors often can be very good advocates and can think about ways of sharing that information with patients that they've learned. It also helps them become more effective in their advisor role. So we encourage you to think about the kinds of training and skill building that you're already doing with staff. And if you have a set of patient advisors or family advisors that you're working with, to invite them to participate in that learning together. Next slide, Kate. So one of the things that's true about primary care is it's not like you fix it and redesign it one day and then there's no change to it the next day. It really is a journey and not a destination. Leadership can come from the top. It can come from influence leaders like an experienced medical assistant or a front desk person who really wants to create a venue and an opportunity to really partner with patients in different ways than perhaps you've done before. And so we really encourage you to think of it as a journey and not a destination, so that you can, in particular, encourage new advisors to join, encourage staff to do some professional development in terms of working as a liaison. Often that's a great opportunity for an up-and-coming, enthusiastic employee. Next slide. Thanks, Kate. I appreciate you moving those forward. So one of my mentors is Bill Schwab. He's a family physician who has been working in the patient and family-centered field for many, many years in Wisconsin. And one of the things that he said, which I thought really encapsulated it very clearly and concisely, was that, and he was speaking of patient advisory committees or parent advisory committees, but and obviously in a pediatric practice, you might have a parent advisory committee as well as a teenage advisory committee. But the most successful advisory committees are those with a clear sense of who's asking for advice, what advice is being sought, and who's committed to hearing and responding to the advice. And it really takes those three pieces working together in order to create a true collaboration. And I like to think that we always want to follow in the footsteps of our mentors, and so I wanted to share Bill's perspective as a practicing physician who understands the complexity and the challenges of redesigning primary care, but also knows the benefit of partnering with patients and families. Next slide. Okay. Bev at the beginning really encouraged you to think of the Institute of Patient and Family-Centered Care as a resource. We have a number of downloadable free documents on our website, but we also do provide resources for publications that we make available to people. And we have a group of publications that are very helpful and can work as companion, I wouldn't call them novels, but manuals. One is Partnering with Patients and Families and Residents, and that would be residents of long-term care communities. But this is a leadership book with lots of examples, not just in the hospitals and ambulatory care, but also in long-term care, of organizations that have successfully partnered with patients and families, and it covers metrics and those kinds of things. We also have an easy guide for staff liaisons with lots of technical tools and easy forms that they can create in their organization to save time. Having worked in busy primary care practices for a number of years, I know that it's not always possible to send somebody off to a 2 or 3 day seminar, but having tools and ideas available for people can often get them on the road to starting. And in terms of orientation, the Words of Advice book is one that was written by advisors who give, seasoned advisors who give other advisors kind of advice about how to be effective. And that can really save some significant time in your orientation, because then you're only providing some context for your organization, and you're also providing a manual and an opportunity for a structured discussion with advisors on that particular role. So we encourage you to create any opportunities you can to learn more about this important work, and to realize that there are many who've come before you that have had a lot of success. And my guess is that there are some of you on the line that have already had some success, but you're just looking for new ideas. And we want you to know that the PCPCI website that Kate manages will have a number of documents that you can download that will be helpful for you. And now is the time for questions.
All right, thanks, Mary. So we only have just a couple short minutes for questions. So I have a couple on deck, and we'll move through those. Just so everyone knows, if you don't get a chance to answer, to ask your question, you can submit a question via the survey that will come up after the webinar, and we will forward your question to panelists and have them get back to you in light of the fact that, that we just don't have very much time for them. So I do have Catherine who wanted to ask her question live, if we can manage it. I've unmuted your line, Catherine. Did you want to go ahead and ask your question?
Yeah, sure. Thank you. So I had a couple questions. I've been doing, we call it co-creation, which is a little different than patient advisory. But I had a question, since you have experience as well. What would you say the common pitfalls or challenges are that you've learned from when you're teaching someone to do this for the first time that you think are important to kind of spell out for them?
Patty, do you want to respond with the patient advisor perspective first?
Well, I think you have to be careful not to inundate too much, you know, and that you give them time to assimilate everything, and then encourage, and reinforce the fact that there's a lot to it, that they will get it, that, you know, it's okay when they come to the meeting. If they would like to share a story, they can. If not, that's okay, that they don't really have to be an up and running, you know, contributor right away.
One of the things that I would, that's great, Patty, and I think that that's really important. It takes somebody who's joining like a quality council or a safety committee that's been ongoing to basically take between 2 to 3 months to really feel grounded in the work. And often identifying somebody, a mentor that they can sit next to, can really help. The other thing is to do debriefing meetings after the first few meetings so that they can ask questions and you can get a sense of what additional support that they might need to feel effective in their role.
This is Bev, and I would add one more thing to the other responses. I think it's really important in those working environments to validate everybody's perspectives and encourage that and kind of reinforce that to set that tone for really authentic co-creation.
Yes.
Hi there, this is Kate. We had one more question, and it was directed towards Patty, but if any of you want to step in, that works too. How do providers best address the patient or parent that does not seem engaged in a preventive health care visit? For example, when they say, we're just here to get this shot and have you sign this sports form.
Oh gosh, that's a real tough question. I mean, you know, that's almost to me asking how do we get people to be better at, you know, managing their own health. You know, that's something that we've struggled with a lot in how we do that, and I think that that's where patient advisors can really be key, because it seems to me that we have just different perspectives. And not every person can think of everything. And so when we engage with our patient advisors, they're bringing up points that the people who are offering the care haven't thought of. And it's not, you know, and that's okay. That's the beauty of a partnership. And I know patient advisors can point out small things that are important for them that may be important for other patients as well.
I have just real quick observation that there was one very small rural practice that worked with a safety net clinic that had a particular day that they basically identified as a sports physical day, and they worked as a team so that people went through different stations in order to get through the process, whether, you know, there might be some shots, there was some quick checking in terms of physical ability, and they had to check into a station that was one where they looked, were able to share what were some of the preventative things that the child needed, so that they were able to schedule them to come back. And so they built it into a day where, at a time frame where most people were able to participate, and so they kind of wrapped it into what people were already wanting.
Great, thank you. And I know there are probably a lot more questions, but we're going to be committed to ending on time today. So I'm just going to remind everyone there's a survey that's going to come up after we end the webinar. Please give us your feedback. It helps us plan webinars that most meet your needs. And there's also a spot where you can type additional questions. And like I said before, I'll forward those to the presenters and be sure to get back to you. You can access materials from this webinar through our website at www.pcpci.org. I will put the slides up immediately, and then a recording will be added later today. But the materials that Patty and Mary were referencing are already linked there, so you should be able to get them from there. And then thank you for your participation today, and thank you to our presenters as well for sharing some of their experience with us.
Thank you.
Thank you.
Thank you.